Thank you for registering for today's webinar where we will discuss the new FQHC Compliance Manual requirements. Today's session will be led by Jeff Adest, a Partner Director at Garfunkel Wild. Jeff represents numerous FQHCs and lookalikes on many complex and day-to-day issues. In today's webinar, he will summarize many, but not all, of the significant changes and clarifications noted in the FQHC Compliance Manual. Today's presentation will run approximately 1 hour. Please use the chat box in the upper right-hand corner of your screen to post questions. We will answer as many questions as possible at the end of the presentation. All other questions will be answered via email. A replay of this presentation will be posted to the Garfunkel Wild's YouTube channel, and we will email that link in the coming days. Again, thank you for registering to Garfunkel Wild's webinar. Now over to Jeff Adest.
Okay, good afternoon, everybody. I'm going to apologize in advance. I lost my voice somewhat over the weekend, so hopefully it'll stick it out for the hour. Also, there's a lot of material to cover, so I don't know how many of the questions we will be able to get to, but if you post them and we can't get to them, I will be sure to respond after the webinar to any of your questions. Just to start with, already a couple of questions have popped up with regard to getting the slides. After the presentation, there will be a link. In a day or two, there will be a link sent out to be able to see replay the presentation on YouTube, and then there will also be a link sent out to be able to get the slides. If you want them more quickly, please send me an email, and we will get them to you in advance. Okay, so as many of you know, the FQHCs are different than pretty much any other kind of healthcare provider with regard to the rules that govern operations of an FQHC. For any other provider, you have a statute and you have regulations, and that's what governs, and they go through a process whereby if they want to issue new statutes or new regulations, there has to be a comment period and the ability to go back and forth and be able to change things and people to be able to argue this doesn't make any sense. In the FQHC world, the last time they updated any statute or regulation was probably more than 20 years ago. And unfortunately, what we've been left to deal with is what was previously known as the PINs, the Policy Information Notices, or the PALs. And so what happened was they would issue PINs or PALs, which are really guidance materials, without going through a comment period and without having people be able to come back and say this is ridiculous. Where that has led is that there are, there were until now probably 25 different PINs and PALs that had different, pieces of governance in them. And if someone came to you and said, give me something to look at to be able to say what I have to comply with, you could not do that easily. You have to, like I say, search through a lot of different documents and sometimes contained contradictory information, or sometimes a year after it was issued, they'd come back and do some kind of amendment and try to explain it, and created a lot of confusion. I'll say, positive thing about it being guidance is that it was just that, which is guidance. And so we have had FQHCs over the years that have come back and said to the government, when you're being cited for something, that what you're citing me for is only in a guidance document. It's not in a statute or regulation, and therefore I do not need to comply. However, most FQHCs are not willing to sort of stick their finger back in the government's eye like that and fight with them, and unfortunately have been forced to listen to things that are included in guidance. The other negative that came out of it is that for all the FQHCs or lookalikes on the phone who have had a site visit, you know that the site visit process is extremely difficult to deal with and predict and to handle as it goes through, right? The problem with the site visits has been that the reviewers, who are not actually employees of the government, just contractors, and I'm not saying through any fault of their own, but because you had all the guidance out there and not contained in one document and no clear set of rules, would apply their own subjective understandings of things, so that you could have two FQHCs who are having a site review at the same time, and both of them could have the exact same document, and in one of them the reviewers say it's fine, and the other one the reviewers say is not This has led to lots of problems, and if for those of you who have heard me speak before, right, what happened about 3 years ago was that, well, before 3 years ago, when the reviewers came, they could come and say, yes, you are in compliance, or no, you're not in compliance, or yes, you're in compliance, but here's some performance improvement things we think you could fix because you're basically in compliance with the element, just little things for you to fix. And you could go back and fix those or come up with a different methodology for fixing it, and you weren't being cited as being terribly out of compliance. About 3 years ago, that was taken away. And so now it's either yes, you're in compliance, or no, you're not in compliance. And what that's led to is, whereas before that, the average non-compliance out of the 19 elements was someplace in the range of 3 to 5, it's now jumped to the average being someplace between 7 and 11. Now, if you think of it, you have to go back to your board and you're out of compliance with 11 items out of 19. That looks terrible. Oftentimes, though, within those 11 things, though, there was some minor thing, right? We had an FQHC that had 50 contracts, and the reviewers found that 2 of them had expired and cited them for being out of compliance. Now, a standard person would say, come on, that's ridiculous. We're in compliance with the element. It's just a detail. But because they took away the ability to do performance improvement, more of the reviewers are citing people for that. The, I guess, positive thing that comes out of this manual is that supposedly this is supposed to be the book you look at, the standards you look at, and remove some of the subjectivity. While I think, HRSA said that was their goal in doing it, practically, as we go through this, you'll see that there is definitely more objectivity, but there still are some subjective requirements. So with regard to the manual, HRSA had issued a draft manual maybe a year ago, maybe more than a year ago, and had provided a period for comments, and it's kind of sat and sat and sat. And going back to the theme of this not being regulation, right, without getting into politics, but in the current era of the new president and not issuing any new regulations, the thought was this would not come anytime soon. However, because it's not a regulation, and I guess it's a guidance document, they were able to issue it. And luckily for me, they issued it an hour before I was trying to leave on vacation. So my kids will be very happy to tell you that the 2 days I tried to take them to Hershey Park, the first day I spent 7.5 hours dealing with all these issues and not being able to spend any time with them. So basically, the new compliance manual is about 90 pages long, and along with it, HRSA issued Q&As or explanations of comments relating to it, which is about another 75 pages long. However, unfortunately, there's no, because of the way the pins were set up before and now having the new guidance, there's no piece of paper that says, here's what it was previously, here's what it is now, here's the differences. They just said, here's what it is now, and in the Q&A, they addressed some of the comments, but not necessarily the changes. So we're going to try to go through today as many of the changes as possible. So just to be clear, because it looks like from some of the registrants, there are people who are non-FQHC related, we are not going to sit and go through each of the elements and talk about what the element is. We're going to go through each of the elements and talk about what changed in the element. So if you want to have guidance as to what each of the elements is, you can contact me directly, separately, and I'm happy to help you with it. But we are not going to sit and go through each element today, just the changes. Okay, so the compliance manual, and for anyone on the phone, is a lookalike, right? Lookalikes, until very recently, were almost unregulated, right? There was an application process. You had to submit the application. Once you had your lookalike status, pretty much you were left alone. To my knowledge, before a year or two ago, lookalikes did not have site visits and just had to, you had the status and you kept the status and that was it. About a year or two ago, lookalikes also started being subject to reviews. I would say a little bit less painful reviews because there are no federal dollars, federal grants that are coming, but it was generally the same standards. The new manual clarifies that everything that's in place applies both to FQHCs and to lookalikes. If there are any subgrantees on the phone, it applies to the subgrantees as well. And so basically all the compliance documents you had before are out the window, with the limited exception of the few, mostly relating to change of scope and service area overlap, the ones that are listed on the screen currently. And again, we will send out the slides. I'll just say for a second, the ones that they kept in place, very interesting to me. Service area overlap. What that pin was supposed to be about is that one FQHC can't open up next door to another FQHC. I think that many of you have probably experienced that over time. While that was a big issue at the beginning, that's gone away. And we see that FQHCs are able to open literally some cases in the same building as another FQHC. So I'm not really sure what the remaining utility of that pin is, but it still is in place. Okay, so in keeping with the theme of change, there are no longer 19 prior program requirements, 19 elements like there were before. There are now 18 elements. However, those 18 elements are now spread across 21 chapters. So go figure out for yourself which of the chapters contain the elements and which don't, and it made it a little bit more complicated. I will also say, and we'll get to this later on towards the end, previously FTCA, right, Federal Tort Claim Coverage, was completely separate, the separate application for it, and the reviews, there were separate on-site reviews relating to FTCA compliance. In the new manual, they have pulled FTCA in, I'll say briefly. There's something on it, a few items on it, which are not as broad as the application was this year. And so it looks like they're going to be including it in their site surveys, but it's not really clear if the site survey is going to address everything that was required in the application. I will tell you that we will be doing a separate webinar with regard to FTCA because many of the requirements this year changed. I'm sure that you saw that in your applications, but I have this concern that people think we submitted the application and we're fine until next year. If you actually read through some of the details, that's not the case. There are significant risk management, FTCA-related actions you need to be taking throughout the year, and you need to be reporting to the board and getting the board to approve things, which cannot all be done in the 5 minutes at the end of the year before you have to submit your new application. I should also mention that the on-site, the HRSA OSV guide, which previously was the basis for preparing for site visits, HRSA has said that the current one is not valid anymore. Unfortunately, I guess dealing with the government, they have not issued a new one. And they are saying that they probably will issue the new one in January. Now, for the FQHCs or lookalikes that have site visits between now and January, that puts us in a very difficult position because we have to prepare for a site visit based on a document that we don't have. So for the clients that I'm working with, I'm still using the old guide as a basis and then applying some of the new rules to it. Okay, so we gave you a couple of slides to go through, right? What was the old 19 elements as compared to the new? What was it, the title before, which chapter is it in now, so you could be able to follow along. I'm not going to sit and go through all of them. I will tell you that some of them previously were considered to be one element are now included in two elements. So if you look at sliding fee, some of the things that previously were in sliding fee are now split between sliding fee and between the billing and collection section and financial management. So if you're trying to compare apples to apples, it's almost impossible. You need to be able to look around and look in different chapters. I will say overall that actually for the first time I could remember, some of the things that were changed are actually very positive and very helpful for FQHCs. And we will go through some of them today, some of them relating to credentialing and board activities. There are some very positive things that come out of this. Okay, so I'm just going to spend a minute on this. The first chapter deals with who can be an FQHC or a lookalike. I just put a couple of these points up. Most of you already are an organization, so you don't have to worry about it. But just so you know, because this has been something I've been fighting with people about for a long time, to apply for an FQHC, they've clarified, which, like I said, I thought was always the rule, that you did not have to actually be IRS 501c3 tax exempt when you apply. As long as you were formed as a not-for-profit, that's okay. Also, for those organizations that are applying for lookalike, the rule has been for the past few years that before you apply for lookalike, you have to show that you're operational for at least 6 months. The new compliance manual seems to take that requirement away, but the application that's up for lookalike, which has not been updated, still requires 6 months of board meetings minutes, so it's not really clear if they really are taking that away. Okay, other things, like FQHCs cannot be controlled by another entity. It can't have a member with some limited grandfathered exceptions. That's the rule. So you cannot have a hospital owning an FQHC, for example. The second bullet point here is just something that's very interesting. And if you get anything out of today, probably the most important thing I'm going to tell you, regardless of the new versus old manual, is you should be periodically checking your form 5A, 5B, and 5C to make sure that they're accurate. So I had a client that was an FQHC lookalike that applied for and ultimately received approval to become a full FQHC. And when they were switched over in the EHB from lookalike to full FQHC, what happened is that they provided some specialty services, and somehow that did not carry over. 6 months after they became an FQHC and HRSA took away the lookalike status, someone was going back to look at something and realized that those categories had not carried over, which meant that for 6 months they were providing cardiology, GI services, things like that, and did not have it in their scope. So you might say to me, okay, so what's so fine? They'll just put it in now. Well, the issues that go with that are if it's not in your scope, then you may have, depending on which state you're in, you may have an issue with regard to whether or not you were entitled to provide those services and whether you have to return all the money you received from it. And more definitively, with regard to FTCA, if the services were not in your scope and a patient got hurt at that time, you will not have FTCA coverage for it, which means that for 6 months they were essentially bare from an insurance perspective with regard to those specialty services. So I will tell you that it's very important that you constantly go back and check your Form 5A to make sure all services you provide are included there. What HRSA was talking about here also is that until now, if you were a lookalike and became an FQHC, you had to give up your lookalike status. Now they seem to be saying that they will allow the dual status. Okay, one thing that is positive is they've said if they put a condition on your grant or they do some kind of progressive action, they've come to realize that what they think is the fix might not be the fix for you or in the real world, and so they've now allowing for alternative means of showing that you fixed it. Also, I don't know if anybody's aware of this. I wasn't aware of this before this this manual came out, but there actually is a website, and if anyone wants it, I could, you can email me and I'll send it to you. There's a website where you can go to where you could check on any FQHC in the country to see whether or not there are any conditions on their grants or any progressive actions that are taking place with them and what their response is to it. So if you want to be checking on other people or you're worried about someone checking on you, there actually is a way for anyone to be able to do that. Okay, generally when you get your FQHC status, it's for a 3-year period. Lookalikes used to be like I said, didn't have a defined period, but now they also have 3-year periods. There are some times where HRSA comes back and says that because of things we found, we're only going to give you a 1-year, re-up rather than a 3-year re-up, and then you basically each year have to reapply. They've now said that if you've gone through that twice, where they twice gave you a 1 year, and now you get to the 3rd year, if you're an FQHC, they could take away your status and not give you the funding. If you're a lookalike, it seems to be that they're not leaving themselves discretion. They're saying if you would get only another 3rd year, we are taking away your status. Okay, so getting now to what was previously the program requirements. This one, is now in Chapter 3, but this is the equivalent to the first requirement from the previous 19 elements. Okay, so needs assessment. What they've changed here is that you do not have to do an annual needs assessment now. You have to do it at least once every 3 years. And they've also stated that the documentation you put together in your 3-year re-up application can yes, satisfy the requirement for needs assessment. However, you do have to now annually review and define your service area boundaries, which is not something that was previously required, and this appears to be something that needs to be approved by the board. Okay, so with regard to required services, and some of these elements you'll see there's more than one slide on. So most FQHCs that I know of, at least, have patients who a significant portion of the patients who speak a second language, might be Spanish, might be some other language, and almost everybody should or does have some process in place for dealing with a patient who comes in who doesn't speak English and needs translation. That might be through having staff who are bilingual or through having a language line that you could call, something like that. And so I think just about everybody has something in place. However, what seems to be changed now is you actually have to have a plan about it, which to me suggests that they're looking for a written document, sort of like a policy and procedure that describes how you deal with patients who don't speak English as a first language and need translation services. So you're going to have to most likely go back and document what it is you're doing into a policy. Also, there's a requirement to provide guidance regarding cultural sensitivities to staff. This seems to apply to all staff, and while you may have been doing this informally, this seems to make it into a more formal requirement going forward. I should mention that for each of the new requirements, and you'll see this at the end, I'm going to give you a list of some things you have to do. We have documents to be able to share with you, to be able to get you into compliance, templates and things like that. Okay. With regard to Form 5A, so there's an issue that's, I guess, depending on the reviewer you had, went back and forth, and I will say that HRSA's determination does not make sense to me, but it's what they determined, so I guess we have to comply with it. So let's say you have an FQHC and you contract with a podiatrist to come in and perform services on site, or a cardiologist or anything like that. The way I would view it is you're performing those services directly, so it should be in column A or column 1. HRSA has said no, that if you're getting the contract through a professional services agreement or independent contractor agreement, even though they're being done on site, that you should be checking column 2, which is the ones where services provided by an outside provider that you pay for. To me, that was always where you're sending it out and you were paying, but HRSA has said no, it should be in column 2. However, because there's no guidance out there, my suggestion would be that if you currently have those services and have them in column 1, you should add it to column 2. I'm not sure if you want to take it out of column 1 at this point or not. You might want to leave it there in case there's some new guidance that comes out about it. I will also say that since August, there has not really been any new guidance about it. There was supposed to be a webcast by HRSA about it, but in the end they pulled back from it, and there was just a couple of minutes about it where they said, check the website because they will be adding new FAQs as things come up. As of yesterday, they had not added any new FAQs, so guidance on a lot of these things have not come yet, but hopefully will come over the next couple of months. Okay, the second bullet point, and this is an issue that comes up a lot, deals with, can I say that I'm only going to give services to a patient who also comes for primary care? So I have cardiology now, and I have a cardiologist that comes in 4 hours a week, and I have lots of patients who are clamoring to get to the cardiologist. And so an outside patient comes and says, I want an appointment with a cardiologist, but that person is not otherwise a patient for primary care. HRSA has said you can say we're giving priority access to those services only to patients who are receiving primary care from us. So this is a very significant change in terms of HRSA putting it in writing. I had been advising clients before this. I thought it was fine, but now HRSA has validated that it is okay. You will, if you're going to do that, you probably need to have a policy addressing how you're handling those requests. Okay. I threw in a few places just some tips about some of these elements if you're having an OSV coming up soon. So if you have anything in column 3, which is by referral, there has to be a contract. It has to be a written contract, not just we have an arrangement with somebody. Something that is significant that they issued now in the new manual is, so let's say lab services. Let's say I have 3 different labs that I send specimens out to. It appears from what they've said that you could, as long as you have a contract with one of those labs, that's the formal relationship, that's okay. For the other 2 labs, you could not have a contract and just define that as being informal and be okay. So that makes it a lot easier in terms of only needing to have one contract. However, if you do have a contract with someone, even if it's the second one, a written contract, that you still would have to comply with all of the required language in there relating to sliding fee and reporting back. But again, it seems like you only need to have one contract for each item that's listed in column 3. Okay. Another change, and this is to me a pretty significant change, is that you can, when you contract for services, you can require, instead of you credentialing all the providers that are coming over, you have a contract with a hospital to provide you with OB staff. Instead of you having to go credential all the OBs, you can, from a HRSA perspective, rely on the hospital. And if the hospital credentialed those providers, you could just get evidence from the hospital, they credential them, and stick that into your file rather than having to credential them yourself. Now, HRSA is not very clear as to what you need to get, but my recommendation would be that you get the same kind of information that you would get if you were doing the credentialing yourself, but instead of having to do it, you just have the hospital essentially give you a copy of their file. Now, I will tell you that I think from the list, there are people in New York, New Jersey, maybe other states. In New York, separate from the HRSA requirements, there is still a requirement for Article 28 to credential people. You may again be able to rely on getting the information from the hospital in my example, but you're still going to need to have your internal credentialing process of actually issuing them credentials. Also, with regard to one of the issues that comes up a lot is how do I determine clinical competence, right? It's something you have to do at the beginning, you have to do periodically. They've now said that it does not necessarily need to be done through peer review. It can be done through other similar methods, for example, being supervisory performance reviews. Also, there is no longer a requirement for the board to approve credentials. I will tell you that, to me, this was one of the strangest requirements that existed, because I've had so many board members say, look, I'm a volunteer. I come to these meetings once in a while. I'm not a healthcare professional, and you're asking me to determine whether or not this doctor is appropriate to be able to provide services at our center. I have no way of knowing that. I have to rely on what you're telling me anyway. Do you think the person is good? Yes, then okay, I'll say yes. So now HRSA has, I think, recognized that and have said that you can now say it does not have to go to the board anymore. It's going to be done by the medical director. The medical director will be the one to review it and give the privileges. It doesn't have to be medical director. I'm just using that as an example. I still think it might be a good idea to just report to the board about we've added new staff and recredentialed and things like that, but you can change it so the board is no longer required to do it. Like I said before, any change that you're making most likely requires change to your policy. So you can't go ahead starting tomorrow and say, okay, it's going to be up to the medical director when you have policies or bylaws that say it's up to the board. You got to go back and change all those documents. Okay. So there was always a requirement to get patient input into hours and sites and things like that. They've now said that they're not going to tell you the method for doing it. It's kind of up to you. You could decide whether you're going to rely on the patient board members or do surveys, patient satisfaction surveys, things like that. It's more up to you to determine how you want to do it going forward. Okay, after hours coverage. So they made a couple of, I'll say, significant changes to this. Right before, the requirements related specifically to services that were provided after hours, not during hours. And now they're saying, no, it has to apply to during hours as well. So you might say to me, okay, that's not such a big deal. During hours, we have some procedure. If someone walks in and keels over at the front desk, we have a procedure for dealing with it. I would guess that you have that procedure, but most people don't have any written document addressing that. So going forward, you now need to have a written document that addresses what you're going to do in an emergency during hours, as well as what you're going to do after hours. You also, and again, depending on the state you're in, this may not be that big of an issue, you have to always have at least one staff member on site who's certified in BLS, basic life support, during hours that you're open to see patients. They're not saying who that person has to be, but there has to be one person at the site. I've heard from a couple of people that if you have late hours where there aren't a lot of staff around, that sometimes this could be an issue. There does not seem to be any flexibility about this, so you're going to have to comply regardless of whether or not you like it. Also, and this last bullet point is one of the things to me that needs significant clarification. They're now saying that you have to have documentation of after-hours calls and required follow-up. So until now, right, I think pretty much the standard procedure is you have an answering service. Answering service gets the call. If it's significant, they page the doctor who's on call. The doctor handles it and deals with the patient and either tells the patient to go to the emergency room or come in tomorrow for a visit or whatever they tell them. What's supposed to have been happening until now is the doctor is supposed to then go document in the patient's chart that on Tuesday evening I spoke to Mrs. Smith and this is what I discussed with her and this was in the plan of care, etc. So I think there have been issues until now from talking to FQHCs with doctors sometimes not doing that or forgetting to do it or you having to chase them to do it. That's not what this is talking about. That remains in place. What they've now said is that they want to, it seems like they want to be able to come in and say, okay, on Tuesday the 15th, tell me how many calls you had and what the outcome of those calls were. So in talking to FQHCs about it, a lot of them tell me, yeah, the next day, every morning I get a report from the answering service telling me last night there was no calls, last night there were 4 calls, here's what I did with them, etc. And that's great. But the question is, how long do you need to keep that for? Right? Most people tell me they keep that, for a few days, maybe a month, something like that. HRSA seems to be saying you have to keep documentation, which arguably could be that a year from now, they're going to come back and pick a random day and ask you for records of what patients called the service that night, which is something that I think is going to be very difficult to be able to track. I would tell you that as of now, the best way I read it is you have to be able to track it. I think it doesn't make any sense, and I'm hopeful there will be some clarification that limits it and says, you only have to keep it for a certain period of time. Because even if you tell me you're going to go back and look at the charts, number one is I don't know that many systems have the ability to look at, do a generic search of charts and say that, on Tuesday, June 15th, these are the people we saw. And the second thing is that if it ended up that it was just a call and the doctor didn't have to document anything, you won't have anything in the chart. So it's going to be difficult to be able to backtrack into it unless you're retaining or requiring the answering service to retain records on a daily basis. Okay, so another thing that deals with patient admissions to hospital, and I have this in 2 or 3 different slides. I'll address it now because I think this is a pretty significant thing. So in the HRSA pre-new manual world, hospitals were sitting around with nothing to do other than waiting for FQHC patients to walk through the door and be able to report to the FQHC every time a patient walked through the door, what their status is, on a daily basis, let them know specifically what's going on with their patients, right? In real life, hospitals are actually operating hospitals and taking care of patients. And when a patient walks through the door where the FQHC did not know the patient went there, almost no hospitals were either willing to, in writing or practically in real life, be able to provide FQHCs with updates on their patients, right? Because until now, the requirement was that the FQHC had to have some way that any patient who walked into a hospital, the FQHC had to know that and be able to have a status track and know what's going on with them, even though they didn't know the patient went. And so we always try to negotiate with hospitals to put that language in the hospital agreements, and for the most part, hospitals pushed back. Unless you were, I'll say, one of the lucky FQHCs that has a hospital you work with where you have access to their system and on a real-time basis and are able to track things, so you could possibly do it that way. So HRSA has now, I guess, come to the realization that that's impossible. And so what they've said is, I'm skipping ahead a slide and coming back. What they've said is, no, that's no longer the case. You do not need to know when a patient shows up at the hospital unless you sent the patient to the hospital. So, the typical scenario where Mr. Smith went to the hospital and then comes back to you a week later and says, last week I was in the hospital, that's okay because you didn't send him and you didn't have to know somehow through magic that he was there. You still do need to, if you send the patient, you still do need to track them and know what's going on with them. And also, even for the patient where you didn't send, you still do need to get the discharge plan, discharge summary from the hospital or from the patient, so you could have that in your records, but you no longer have to go back and you require the hospital to notify you as soon as the patient comes. Also, HRSA has clarified that if you have patients who go to 3 different hospitals, you do not necessarily have to have your physicians have privileges at all of those hospitals. It's up to you to determine which of those hospitals you are going to use. And actually, it's up to you to determine whether or not you're going to have your providers have privileges at hospitals, period. From the way HRSA has drafted it in the new manual, you could decide that our internists or our pediatricians are no longer going to go to the hospital, period. Now, you may have an issue with the hospital in terms of them not being happy with you because you're not sending your providers anymore, but from a HRSA perspective, you do not need to do it. You still do need to have information relating to getting information and recording it and follow-up, right? So if you're getting the discharge plan, you still need to have that and have a process of following up based on a discharge plan. And my understanding is that there are many FQHCs who will get on a regular basis from the hospital all the discharge plans. The hospital will send by themselves all the discharge plans for patients who identify themselves as being FQHC patients. You can't just get the record. If you get the record, you have to do follow-up on it. You also, if you send the patient, have to be getting all the information and do follow-up on that as well. Okay, there was a clarification, and this comes up here and comes up in the next section, so I'll talk about it now as well. Right, sliding fee. The requirement for the hospital first of all, the requirement for the hospital to comply with sliding fee only applies to in-scope services. So if a patient goes to the hospital for something that you're not sending them for, again, basically an outpatient visit. They go to the hospital, show up in the emergency room, get admitted. The hospital does not have to comply with FQHC sliding fee requirements for those patients. With regard to sliding fee in general, right? So again, I would say HRSA living in the theoretical world rather than necessarily the practical world. What happens, and this is one of the biggest complaints I get from FQHCs, is, okay, so we don't provide these services, so we have to find someone else who's willing to take our patients, right? For the most part, the overwhelming majority of your patients are either Medicaid or self-pay or no-pay patients. And so, as a general course, providers are not banging down FQHC's doors to get their patients to come to them. And so, for example, if you don't provide dental, you need to send it out to somebody. Or you don't provide your radiology services and you have to send it out. So now the radiology companies are not begging for your Medicaid and no-pay patients. But what was required until now was, and continues to be required to some extent, is that you have to somehow get them to agree not only to take your patients, but to apply your sliding fee discount. So I will tell you that when you go to a hospital and tell a hospital that even though they have their own sliding fee policies, their own charity care policies, they have to apply a different one for your patients, the chance of the contract not being thrown back in your face or you're not being laughed out of the room is very, very small. And so what we've done over time is we've gotten HRSA surveyors to agree that if we put language in the agreements that says that the hospital is going to comply with its own charity care policies, which provide discounts to patients under 200% of the federal poverty level, HRSA has generally accepted it. I was hopeful that they would put that in writing this time. They actually did not. But again, in the real world, I think that's pretty much your only option. But the positive, which I mentioned a little bit earlier, is that, again, you only need to have, for anything in column 3, one provider who's agreeing to it. So if you have a contract with the hospital and the hospital is willing to put in the language about complying with their own charity care policy, and now you send patients for radiology to the hospital and to a private radiology group, you no longer are required to include that in the private radiology group, assuming you don't have a contract, and treat that as an informal relationship rather than a formal relationship. Okay, other things that they've clarified, and I'm not hitting on everything that's on the slides, just picking because we're starting to run out of time, is that you can have a nominal charge. If you have different charges, let's say you have one fee schedule for medical and a separate one for dental, you could have different nominal charges for them, but you have to actually have two separate pieces of paper, one that says medical sliding fee and one that says dental. You can't, in the same piece of paper where it says sliding fee, say sliding fee for medical is $10 and sliding fee for dental is $20. It seems to me to be a lot of form over substance. I'm not sure that I understand it, but it's a requirement, so you have to comply with it. Okay, what they've changed also is that the sliding fee, it still needs to be a policy. The policy only needs to be evaluated at least once every 3 years. It does not have to be every year as previously required. However, as a practical matter, at least generally the sliding fees are based off the federal poverty guidelines, which are issued once a year. So when they issue new guidelines, you have to go ahead and change your documentation. So you probably will in the end need to go back and have it changed every year anyway. Okay, they've also said, going back to what the sliding fee is, that if the other provider, the radiology company sending it to, doesn't want to apply your sliding fee, has their own sliding fee, and their sliding fee has greater discounts than yours, that's okay. Right? This sometimes come up in lab situations where the labs say, I can't deal with the sliding fee. If you tell me this patient is your sliding fee, I'll just do it for a nominal fee overall. I'll do it for $10 and that's it. HRSA has clarified that's okay. Something else they've clarified is that there's a requirement to have under 100% this nominal fee, and then between 100 and 200%, you have to have 3 separate categories. The actual discount within those 3 categories needs to be different, right? It could be a dollar amount, it could be 15, 20, 25, or it could be 10% discount, 15%, 20% discount, whatever, but it has to be different within those 3 categories. Also, now up to you to determine whether you're going to treat patients who refuse to fill out any forms or give you information, or what you're going to do with them. You could turn those patients away. Okay, I'm going to skip through the tips for now. They'll be in the slides. Okay, QA. They've significantly changed QA. First of all, there's no longer a requirement for the QA director to be a physician. Right? It can be done. It can be any person you want to appoint. It could be to someone who does not have any, someone has a master's, or someone who doesn't have any kind of medical degree at all can be the QA director. However, the clinical assessments, the peer review or things like that still have to be done by clinical staff. This is, to me, significant because it no longer has to fall on your medical director. It could fall on an administrative person to do most of it. You have to do QA on a quarterly basis, and the QA policy has to be reviewed every 3 years. However, right, for those of you who are familiar with FTCA, when they say you have to do QA only on a quarterly basis, at the FTCA applications in the past have always required evidence of at least 6 meetings during the year, and there's nothing in this manual that takes that away, so it's not really clear. If you only do quarterly, you might end up having a problem that in June or July when you have to fill out your FTCA application because you won't have 6 meetings. So I would tell you for now, until something changes, that you should still continue to have at least 6 meetings so that you can meet the FTCA requirements. Okay, so HRSA has clarified, and I think this again will be a big issue to a lot of FQHCs, that first of all, the senior management do not have to be direct employees. You can contract for any of them. If it's going to be the CEO, you can only contract with HRSA's approval. Whether or not they'll give the approval is not clear. I mean, previously they did not even have that ability to get the approval. Now they put it in place. But for the rest of the people, they can be contracted. They do not need to be direct employees. Also, key management staff can be part-time. You don't have to have a full-time CFO. It can be a part-time person. One person can have two different jobs, right? One person could be both the CEO and the CFO. Those are all fine. I should have mentioned before also, for clinical staff, right, there was always a requirement that the majority of the primary care providers had to be direct employees. That no longer exists. They can be contracted. You do not need to have direct employees anymore for your clinical staff either. They can be contracted. The only exception is that if you're contracting with one outside entity for the majority of your providers, you might need to go back and get HRSA approval depending on the specific details, which I could address with anyone individually. But otherwise, staff can be contracted. You don't have to have the majority being directly employed. Also, and to me this is a silly thing, so when I first started working here and we did contracts for like medical director or CEO or something like that, there was always like you had the whole contract and at the back had a job description. At the bottom of the job description you had what are their background qualifications, training and experience qualifications they had to have in order to get the job. And it never made any sense to me why you would put that on the job description, because you already hired the person and made the determination that they have the right experience, otherwise you wouldn't have hired them. However, for whatever reason, HRSA doesn't agree with me, and they've said you have to have on your job descriptions what the requirements are for training and experience. So anyone who's taking them off has to now put them back on, even though the person is already working for you. Okay, so this is an issue that's come up in the past. The procurement rules only apply if you're using federal dollars. I would tell you that your regular annual grant that you get, you should not be buying anything with it, so you don't have to worry about these procurement rules. You should be, allocating that to staff, time and effort of staff, rather than buying anything, so you don't have to comply with the procurement rules, which are very, very complicated. Where you will have to comply with the procurement rules are if you got a construction grant from HRSA, then you're going to have to go through all these rules and all the details that go with it. But there had been a bunch of discussion over the years and people taking positions that any dollars you spent, even if they weren't federal grant dollars, but if they were federal program dollars, Medicare, Medicaid dollars, you had to comply with procurement. They've said straight out, you do not need to do that. Now, I will tell you as a IRS tax exempt organization, that does not mean that you don't have any procurement requirements. You still have to worry about bidding and doing things like that on larger projects. But what it means is you can have your own policies, which are different than the federal procurement rules, which were completely over the top and very difficult to deal with. Okay, conflict of interest. They've clarified, which should have been your process until now anyway, that you can't have an employee, officer, or board member participating in the awarding of a contract if there's a real or apparent conflict of interest. I would tell you that my recommendation is that you never enter into a contract with any one of those people, right? If it's someone's relative or someone on the board has a company that you could contract with, I would tell you should not be contracting with them to avoid any conflict issues. But if you are going to do it, they have to be excluded from it. I would tell you as a not-for-profit, you should be getting other bids as well to be able to show that what you're paying actually is accurate. I've found over the years that, the large majority of the time, if you're contracting with someone who's related, while at the beginning it may have been fair market value, when you get 3-4 years into it, all of a sudden you realize we never raised the prices, or they never changed the prices, and now if we went out and contracted in the market, we could buy it for a lot less, and we didn't, and it only comes up when there's an investigation. Also, something important is that the conflict of interest forms, the disclosure forms you fill out, someone has to pay attention to them. It's not just annually filling out a form and submitting it, right? I just dealing with a scenario where someone filled out a form and submitted it and said they had no conflict, and we went back and looked, and they have a tremendous conflict. They're actually in direct competition with the organization. So just filling out the form and say we got the forms filled out is not okay. You have to pay attention to the realities and make sure they're reflected. Okay, collaborative relationships. This one to me, I was one that if you would tell me they were going to take one out, I would have thought they were taking this one out because it just seems silly, right? It's saying you have to be part of the world and have some collaborative relations with other organizations. They've clarified what they mean is not the Form 5A, that they mean other providers. They want you to know what's going on in the world and what's going on in the healthcare industry and have other people you talk to. So you have social services agencies, you have other agencies like that. You're part of your primary care association in your state. Those are all things that cover it. But they now want you to, again, to clarify, they want to be able to see that you have relationships with other non-FQHCs. Also, if you're doing a change of scope or adding a new site, they want you to try to get, collaboration letters from other providers serving similar populations, other FQHCs. They've said, which has been the practice for a little bit of time, but was never in writing, they've now said that if you can't and you document that you tried, that's okay. Okay, financial management. So like I said before, if people remember, I don't know, maybe 3 or 4 years ago, there had been a draft pin that came out where they said basically if you want to use any money for something that's not a specific line item in your budget, you're going to have to go back and get approval from HRSA. And the whole world went crazy about it, and they backed it off. They've now gone full circle and basically said you can do anything you want with your money, that any excess money you have, as long as it's not specifically prohibited. So that's very good. And you don't have to, like I said, you don't have to comply with the federal grant dollars if you're not talking about federal grant rules, if you're not using grant dollars. I will tell you that this is the area when I do my site prep reviews where I find the biggest problems, because people have policies that were written 15 years ago, and the policies are very nice, except they don't reflect any of the realities of what's going on in the organization. I sit down and I say to the CFO, okay, tell me how you do this, how you do that. And what they tell me is fine. It doesn't match at all with the policy. So I would tell you that what's in the policy has to match what you're doing in real life. Also, I have found that many FQHCs use very antiquated systems with regard to financial management. So on a simple level, the person ordering the supplies should not also be the person who's getting supplies and opening the boxes, because you have no way of knowing what they're ordering and checking it. Cash management is a big issue, right? You don't get that much cash, but there's cash that comes in. There needs to be a process whereby, again, it's not one person who's overall responsible for the cash, and you have no way of tracking how much cash really came in and what happened to it. I'm running out of time, so I won't tell you some of the horror stories I've seen, but suffice it to say, there's been a lot of problems we found with that. Okay, billing and collection. So one of the things which they clarified, which is not necessarily on the slide, but I'll just tell you about, has come up is, right, so everyone knows that from a HRSA perspective, you cannot give discounts to anyone above 200% of the federal poverty level. So what that means is, if you look at it, a family of 6, parents and 4 kids, make something like $14,000, you can't give them any discount, because people who make $14,000 and have 4 kids can definitely afford to pay $150 or $250 for a visit because they have all this disposable income. But HRSA has always said you can't do it. They changed in about 2 or 3 years ago to finally say that if you have other grant source dollars or other dollars that are non-program specific dollars, you can give discounts above 200%. I'd like to believe they changed that because of things that have happened with us, because we had FQHCs that had to give up a lot of money in state grant dollars because of this federal requirement. So they've changed it. But something else that comes up a lot, okay, is I walk into the clinic, right? I'm thankfully above 200% of the poverty level. And I walk in and I say, I want to get services today. And I say, and someone says to me, okay, our rate is $200. And I say, I'm not willing to pay $200. If you'll take $50, you can treat me. If not, I'll go down the road to somebody else, and that's it. You cannot apply a sliding fee discount to me, but you can agree to take a lesser fee. So you're not applying sliding fee. You're just saying, I'm saying only pay 50. You're saying, okay, fine, we'll take the 50 because 50 is better than nothing, and we have an empty slot anyway. There are rules around that, so I'm not making a generic blanket statement. You can do it for anything. There are things, policies and procedures you have to put into place around it, but it can be done, and I'm happy to follow up with anyone about that. Also, what they've said is you have to document that you are making collection efforts. People who don't pay, and you got to send them a bill. You can't just not send them a bill and say, it probably cost me more to send the stamp than I'm going to collect. I agree that's probably true, but HRSA is saying you still have to make efforts to collect. Okay, you have to show that you've tried to bill and you've made efforts and tried to get contracts with people. That that's different in New York and New Jersey with the super wrap in New York that doesn't exist in New Jersey. But you have to show that you have records showing you tried to get paid. Okay, just some other tips that are up here, which you'll get. Okay, budget. So HRSA has stated that if you have services that are out of scope, you can no longer include them in your budget. You have to have two separate budgets, one for things that are in scope and one for things that are out of scope. And for the CFOs who are throwing things at the computer, it's not me who made this rule, HRSA made the rule. So you literally, when you have a board meeting, have to have two separate documents, or two separate pages that clarify this is within scope and this is out of scope. Okay, just with regard to budget, I'll just tell you that the surveyors like to see, and everyone laughs when I say it, but it's really true, they want to see pictures. I would say at least quarterly you should be having graphs that show where you are as compared to other FQHCs, or what percentage of your patients are for each payer or from each insurance company. They want to see that the board is getting some pictures. Important to do that. Okay, UDS and program monitoring and data is pretty much the same. They now say specifically you have to have reports on patient service utilization, trends in the population, and overall performance. Okay, board authority. I'll say probably the best thing is and I think it's on the next slide, you do not have to have committees anymore. There's no longer requirements to have committees. It's up to you to decide whether or not you want to have a committee. If you ask me, I would tell you that I recommend you still have an executive committee and a finance committee. But with regard to the other ones, you do not need to have them. They don't need to necessarily meet as often as possible as they did. If you get rid of your finance committee, you're still going to have to do the finance report to your board on a monthly basis. So you may want to keep it for that reason, but otherwise you do not need to have committees. Also, the board is not required to perform a self-assessment anymore. Also, you can have an executive committee that can take action in between meetings in time-sensitive scenarios. It's something we've thought about with HRSA for years, and they've come to say yes. You have to have strategic planning now only needs to be done once every 3 years, but you also have to have a 3-year plan for financial management and capital expenditures. If you're not going to expend capital, you don't have to have for that. You still have to have for financial management, but if you are going to be spending money on capital, you have to have a 3-year plan for that. The review of the CEO does not necessarily have to be done every year. It's up to the board to determine. I would tell you that anything that doesn't have a time frame should never, in my mind, should never go more than 3 years, but it does not have to be annually anymore. There are some policies. So they've also clarified the board does not need to review and approve every single policy. Basically, they gave a list here, which is sliding fee, QA, billing, collection, and other policies involving financial management, accounting, and personnel. But like healthcare policies do not need to be approved by the board. Board composition, they've said that the restriction on healthcare board members, it's now up to you to determine who's a healthcare board member. Previously, like I always said that I was a healthcare board member because I make my money from the healthcare industry. Now the board of the FQHC can determine that's not a healthcare person to us, only a clinician is a healthcare person. Okay, with regard to deeming, the FTCA, so like I mentioned earlier, there are significant risk management requirements that talk about doing risk management and doing training and having risk management goals and reporting back to the board about it. And like I mentioned, we're going to do a separate presentation about that. So watch out for it because there are a lot of detailed requirements about it. You have to provide actual documentation relating to all of it. Also, this will be the last thing because we're out of time. You have to notify patients that you are a deemed federal public health service employee. What that means in English is that you're covered by FTCA. But given they've said this, I would tell you got to put on your website or someplace else the words, we are deemed a federal public health service employee. Okay, next steps. So there's a lot of things you have to change. Your Form 5A, your bylaws, your policy, credentialing policies, sliding fee, referrals, QA, job descriptions, and there's a whole list, risk management policies. Like I said, you need to change and that we can help you with. Unfortunately, we are out of time, so I'm not going to be able to get to questions. But like I said, if you submit your questions, I will be happy to respond to you by the phone or by email. Reach out to us and look, like I said, for a new presentation coming up with regard to FTCA and risk management. Thank you for joining today.